In this video, I am going to talk about drug interactions. Many patients, especially the elderly, are treated continuously with one or more drugs for chronic diseases such as hypertension, heart failure, osteoarthritis, and so on. Acute events, example infections, myocardial infarction, are treated with additional drugs. Therefore, the potential for drug interactions is substantial. Clinical judgment should be used where the patient is treated with multiple drugs, especially with coexisting diseases. Drug interactions can be discussed on the basis of pharmacodynamic interactions and pharmacokinetic interactions. Pharmacodynamic interactions. The interaction between beta blocker and salbutamol. Salbutamol is commonly used for the treatment of bronchial asthma and acts by stimulating the beta-2 adrenergic receptors of the bronchial smooth muscles. Beta blockers, when administered along with salbutamol, diminish the effect of salbutamol and aggravate the symptoms of acute bronchial asthma. Second example, the interaction between diuretics and digoxin. Diuretics act by eliminating sodium-potassium water from the body, leading to hypokalemia. Hypokalemia predisposes to digoxin toxicity. The interaction between organic nitrates and sildenafil. Organic nitrates acts as an antihypertensive agent by stimulating guanylate cyclase enzyme which converts GTP to cyclic GMP. Cyclic GMP acts as a vasodilator and decreases the blood pressure. Sildenafil, which is an inhibitor of phosphodiesterase enzyme, fails to convert cyclic GMP to 5-AMP. So sildenafil, when administered along with organic nitrates, increases the concentration of cyclic GMP, thus leading to excessive cyclic GMP mediated vasodilatation, leading to hypotension as a side effect. The next example is the interaction between MAO inhibitors and tyramine-rich food. MAO inhibitors inhibit degradation of norepinephrine in noradrenergic nerve terminals, thus increasing the storage of norepinephrine in the nerve terminals. Tyramine-rich foods such as cheese release the stored norepinephrine into the synaptic cleft, thus increasing the concentration of norepinephrine and leading to acute hypertension. Next example, the interaction between warfarin and aspirin. Warfarin reduces the hepatic synthesis of clotting factors and exerts anticoagulant action, whereas aspirin inhibits platelet aggregation and clotting. Therefore, warfarin when administered together with aspirin increases the risk of bleeding, especially from the stomach. Next example, the interaction between sulfonamides and trimethoprim. Sulfonamides inhibit folate synthesis and prevent the conversion of dihydrofolic acid from PABA, and trimethoprim inhibit dihydrofolate reductase and inhibits the conversion of dihydrofolic acid to tetrahydrofolic acid, which is required for purine synthesis, DNA synthesis, and bacterial multiplication. Therefore, synergistic action between sulfonamides and trimethoprim is of value in the treatment of pneumocystis carinii pneumonia. Next, we move on to pharmacokinetic interactions. Examples are as follows. 1. Calcium forms insoluble complex with tetracycline and inhibits absorption of tetracycline. So, tetracycline absorption is inhibited in presence of calcium-rich food. Second example, the interaction between cholestyramine and warfarin. Cholestyramine is a bile acid binding resin and inhibits the absorption of warfarin or digoxin when administered together. The third example, the interaction between adrenaline and lignocaine. Adrenaline is a vasoconstrictor of blood vessels and lignocaine is a local anesthetic. When administered together, adrenaline slows the absorption of lignocaine into the systemic circulation and prolongs the effect of lignocaine. There are several instances where drugs can alter plasma protein binding and additionally reduce the elimination of the drug. For example, phenylbutazone displaces warfarin from plasma protein binding sites and increases the concentration of warfarin. So if the metabolism of warfarin is inhibited, the increased concentration of warfarin can increase the risk of bleeding. This is because warfarin has a narrow safety margin and small increases in plasma concentration of the drug can lead to increased risk of bleeding. The second example, salicylates displace methotrexate from plasma protein binding sites, thus increasing the concentration of methotrexate. And if the secretion of methotrexate into the nephrons is reduced, this can lead to methotrexate toxicity. The third example, quinidine verapamil amiodarone displace digoxin from tissue binding sites, thus increasing the concentration of digoxin. If there is reduction in renal excretion of digoxin, the digoxin concentration increases and this can lead to digoxin toxicity. Next is drug metabolism. Drugs can stimulate or inhibit the synthesis of drug metabolizing enzymes leading to drug interactions. For example, rifampicin can cause contraceptive failure when administered together. This is because rifampicin induces the synthesis of cytochrome P450 enzymes which metabolizes oral contraceptives. Due to stimulation of metabolism, there can be contraceptive failure. The second example is that of rifampicin, which decreases the effectiveness of warfarin due to increased metabolism of warfarin and decreasing the anticoagulant effect. Next is enzyme inhibition. Examples are the interaction between ketoconazole and terfenadine. Ketoconazole inhibits cytochrome P450 enzymes which metabolizes terfenadine. Due to inhibition of the enzymes, the terfenadine concentration increases and this leads to prolongation of the QT interval. The second example, the interaction between allopurinol and mercaptopurine. Allopurinol is an inhibitor of xanthine oxidase which converts xanthine to uric acid. Mercaptopurine is metabolized by xanthine oxidase and allopurinol, by inhibiting xanthine oxidase, prolongs the action of mercaptopurine. Therefore, allopurinol when administered together with mercaptopurine, the action of mercaptopurine is prolonged or potentiated. The third example, the interaction between alcohol and disulfiram and other pharmaceutical agents that produce disulfiram-like reactions. Disulfiram causes an adverse effect with alcohol due to inhibition of aldehyde dehydrogenase and increasing the concentration of aldehyde, leading to symptoms of nausea, vomiting, abdominal pain, chest discomfort, dizziness, throbbing headache, palpitation, and so on. This leads to aversion of alcohol. Several pharmaceutical agents can cause disulfiram-like reaction. For example, intake of alcohol in a patient who is on metronidazole therapy can experience disulfiram-like reaction, and therefore the patient is advised to restrict the use of alcohol during metronidazole therapy. Drugs such as penicillin and probenecid are excreted by tubular secretion. Probenecid, having higher affinity for the transporter, inhibits the tubular secretion of penicillin, thus prolonging the action of penicillin. So, probenecid is administered along with penicillin to prolong the duration of action of penicillin. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.